Our next speaker is Dr. Nabil Dib. He's internationally known in the field of cardiovascular medicine. He's a founder and director of International Society of Cardiovascular Translational Research. He's the founder and editor-in-chief of the Journal of Cardiovascular Translational Research. He's a professor of medicine at University of Arizona. He's professor of clinical cardiovascular cell therapy at University of California, San Diego. And he has written numerous papers. If I start reading his resume, I'll be probably spending not an hour, maybe a day. He's, more importantly, he's a very good friend. He's a colleague of mine. We work together at Dignity Health. In a way, he is head of the research program. So Dr. Dib, you can take over.
Thank you so much, Dr. Shah, for your nice introduction. I truly wanted to be with you. I'm really sorry. I planned my time is wrong. It turned out I'm on vacation when Dr. Shah told me to give this talk in his meeting. So here we are today, and I am very happy to talk about the current guideline for cardiovascular medicine. I have nothing to declare regarding this talk. We have done a good job over the years. If we look at the time between the 1800 and 1950, the average lifespan was 29 years, increased to 46 years. So it took us about 150 years to increase our lifespan by 17 years. We're doing better over time. From 1950 to 2015, which is over 65 years, we improved the lifespan by 25 years. If we look at the impact of cardiovascular medicine over the last 30 years, in terms of life expectancy, it did not contribute a lot. Actually, is on average 1.3 years we improved the life expectancy. And according to the Human Development Index, a country with a high index, the average lifespan increased by 2.3 years. And a low index by 0.5 to 0.8 years. And we spend a tremendous amount of money in the US, as you see in cardiovascular medicine. The result overall in terms of life expectancy in the United States comparison to other countries, as you see here in this slide, United States patients now or people live 5 years less than a country in similar outcome. Still, cardiovascular mortality is number one cause of death, as you see here. In 1 year, on average, we have 800,000 people die from cardiovascular disease. If you take even the COVID is even association, not necessarily causation, is way less than that. It's half of cardiovascular death. The clinical practice guideline, I think, is important because it provides a real evidence of medicine and what we should and we should not do. And we need to be very careful about the definitions. A class 1 indication means the therapy has a significant benefit relative to the risk. While class 2A, the benefit is less than class 1A, but still there is a benefit more than risk. And when we start talking about the class 2B, the benefit almost the same like risk or maybe more. But as you see, this is a very important, the magnitude of effect of therapy is critical when we are going to make a decision for patient, depending on how sick they are and so forth, and how much risk we are going to take. And the class 3, the benefit equal risk, and the class 3 harm, there's two classification. Class 3, no benefit, and class 3 harm. And harm, the risk or exceed the benefit, as you see. And the other classification, part of the class 1 and 2 and so forth, is the level of evidence, how accurate what we are saying the benefit is. And that depending on the clinical trial design and the input, how strong is the design, is no bias, no confounder. And now they are adding another element to the guideline, which is level of value, which is mean quality of adjusted life per year for patient. And they took those numbers from the dialysis patient. So the country is willing to pay $50,000 per year for dialysis patient. And they took that as a benchmark, and they said, okay, if we have a therapy that cost us 50,000 or less for quality adjusted life per year, then that's considered high value, is a good therapy. Intermediate value between 50 to 150,000, and low value if it exceeds 150,000. Those are going to be involved in the guideline. Why guideline is important? It's very important because it provides a scientific evidence, not a physician judgment. As you see, physician felt for a long time that aspirin is a great therapy for the prevention of cardiovascular disease. And when they ran the clinical trial with a good design, all what they saw that there is no much of a benefit for prevention. In the European classification guideline now, aspirin class of 3 for prevention, and the class 2B in the American Heart Association and ACC guideline, or the guideline that we are talking about today. And as you see here, really aspirin for prevention only for patients between 40 and 70 years of age who have high ASCVD, which is atherosclerotic cardiovascular disease risk score, something we do all the time in NAFIS, and you are going to hear about, and has low risk of bleed. So that's the only time when aspirin. And what benefit? A class 2B, which is a benefit or risk almost the same, maybe a little bit more benefit. And those are important to remember, to know the magnitude and the impact of what we do. In terms of, as you see, I'm going to go a little bit fast, but I'm not going to go in detail over everything, but just the most important probably data that we use in the clinical practice almost every day. So I selected those from the guideline, and I'm going to go over many of the cardiovascular disease guideline. The most important thing, the healthy lifestyle. The 7 points: activity, weight reduction, low cholesterol, no smoking, good diet, low blood pressure, normal blood pressure, and diabetes. Those are the elements that we need to control. And if we control that in a prevention way, we can, the patient live 12 years longer and 14 years free of all cardiovascular events. This is extremely valuable intervention to do for our patient in terms of prevention. In terms of the risk factors, treating the cholesterol, I am summarizing here the few points as you see on the left, summarizing all this complex slide. If somebody has cardiovascular risk less than 7.5, the LDL have to be 190 to treat. If it's not 190 LDL, you don't need to treat, and you don't need to have the side effect of the therapy. If a patient have diabetes, you treat with a statin for primary prevention. If his score, the atherosclerotic cardiovascular risk score more than 20, you treat. If the score more than 7.5 plus enhancer, which is mean family history of heart disease. You see all those patients in the clinic all the time have significant family history, has a kidney disease, and so forth. CRP high, the calcium more than 100 score. Those are called enhancer. So as you see here, we always need to calculate this score to know what to do with patient. I do that routinely in the office. Every patient come, he will have the atherosclerotic cardiovascular risk score for 10 years and lifetime. For the secondary prevention, however, which is mean patient have a previous known coronary artery disease, heart attack or stroke and so forth, the LDL goal is to be less than 70. So we always start with high intensity statins. And if the LDL continue to be more than 70, the next step we'll use ezetimibe. And if that continue after dose, usually we check the cholesterol in 2 to 3 months. If the LDL continue to be more than 70, then we add the PCSK9 inhibitors. So that's order is important. In terms of so that's much for the cholesterol. So it's easy to remember those points. For the primary prevention, we don't really treat unless LDL more than 90, or they have the following point. For the secondary prevention, you see that our goal for the LDL to be less than 70. That's very much for cholesterol. For blood pressures is a major problem. Prevalence of hypertension now in the United States, 45 people of adult have blood pressure more than 120 over 80. So it's a common problem. However, when do we treat blood pressure? We treat blood pressure only if the blood pressure systolic more than 140 and diastolic more, or diastolic more than 90. Or second situation, if the score is more than 10, then we treat the blood pressure when it is more than 130 over 80. So as you see, we're always calculating the risk score because we are kind of calculating risk benefit of therapy for patients. For diabetes, our goal is the definition of diabetes, hemoglobin A1C more than 6.5 or equal. And our goal always to have the hemoglobin A1C less or equal to 7. That's when the cardiovascular event at its lowest level, when the hemoglobin A1C less than 7. And here what you see is very interesting in terms of prevention. To reduce this by 50% in a smoker. If we lower LDL by 40 milligram per deciliter, we reduce mortality by 30%. If we lower the blood pressure by 10, if the blood pressure more than 140, we reduce the cardiovascular mortality by 25%. So the three together reduce risk by 75%. And I am emphasizing on a prevention, even though I'm an interventional cardiologist, because this is really where the problem is. In terms of the, for the chest pain guideline, number one, only 10% of patients present to the emergency room have coronary artery disease. The 90% would not have coronary artery disease, even though they have chest pain. So it's not the most common thing in emergency room when patient coming with chest pain. So that's just, I think, is important statistic. But what also I would like to mention in the guideline, they have a change the description of atypical chest pain. No anymore they would recommend to describe in the history and physical atypical chest pain. They say it is described as a cardiac, possibly cardiac, or non-cardiac. So that's a change in the definition of chest pain. And in patient with chest pain who are over 75 years of age, even if they present with syncope, delirium, or unexplained fall. So delirium and unexplained fall, that could be an acute coronary syndrome in elderly people. So that's introducing new to the guideline. In terms of the creatinine kinase, CKMB, not anymore useful, or we don't use it for the purpose of diagnosis, since we have now the troponin. And the reason, because of the troponin is much more accurate. And the high sensitivity troponin is a class 1, is a preferable to have high sensitivity troponin. If not, you can obviously use the troponin. To repeat the measurement, for the high sensitivity, you can repeat it between 1 to 3 hours. So it's a very fast test. Between the other troponin, between 3 to 6 hours, you repeat it after the first measurement. This is maybe a little bit interesting from practical point of view. If patient have cardiac cath or CTA and his coronary artery completely normal, and it presents 6 months later to emergency room, you can almost say that's probably not coronary, because those kind of tests, when you see a normal coronary, almost guarantee 2 years, a period that very unlikely that patient will have coronary artery disease. The stress testing is 1 year. So kind of from clinical practice decision, we see all the time patient coming to emergency room, they just have a cath 1 month ago or 2 months ago, coming back again with the same chest pain. Well, this is unlikely to be cardiac pain. If you are suspect of aortic dissection, any test is fine, whether cardiac CTA, TEE, or CMR, all of them class 1 indication. For stable coronary artery disease, we tend to do a lot of testing, and that's kind of a change now. And literally, I summarize this in a few bullet points on the left. In general, in women, if they are less than 60 years of age and man less than 40 years of age, the likelihood or the pretest probability is very low, less than 15%, and stress test is not going to help you much. Routine stress test is not required for this age in general. Doesn't matter even if the chest pain look like typical. The likelihood of disease is very small in this age population. If you have a high suspicion, obviously you can proceed with the test, but in general, routine is not needed. And here you go, when you have a low probability, less than 15% chance, no test is necessary. Option for calcium score or assessment according to the ASCVD. If the age is less than 65, between stress test and CT, if the age less than 65, CT is probably preferable, and if it's more than 65, stress test is probably preferable. And the reason, older population have a lot of calcification and always the image compromise when you do CT if you have significant calcification. That's in terms of diagnostic for stable coronary artery disease. In terms of the revascularization therapy, we improve survival in patient when we revascularize them only if their ventricle is not working well, the ejection fraction less than 35%. Then CABG is recommended to improve survival. And that's what the method of the revascularization now with severely reduced, coronary artery disease and severely reduced ejection fraction. Also, CABG for left main is still a class 1 indication. If you have left main disease and if you have multivessel disease with a reduced ejection fraction, CABG is a class 1 indication. PCI class 2A for the left main if it's suitable and you think will give you a good option. This is a new, and this is really interesting, revascularization in patient before non-cardiac surgery. No benefit, no benefit. We used to do constantly, anybody want to do any surgery, we stress them out to make sure that they have no disease. Unless the only time, if you are really suspect of left main disease or very high complex coronary artery disease. That's the only time. Otherwise, no benefit to do that routine testing just because you want to clear somebody. I have in my office many people come just for endoscopy for clearance. Absolutely not. This is very low risk and it's not required unless patient literally cannot breathe. And we are talking, remember, on a stable patient, not acute coronary syndrome. Acute coronary syndrome, completely different game. This is a stable patient. For the treatment of calcified lesions, and I know some of you is not cardiologists, but for the cardiologist, now rotablator for calcified lesion class 2A, and orbital atherectomy and lithotripsy are class 2B. And we have many clinical trials now, like the Eclipse and others, running for orbital atherectomy to bring that, to see if that device can do better. And obviously the industry always looking to be in a class 1 indication. Treatment of chronic total occlusion. And you see many institutions with programs for total occlusion. And look at the classification, class 2B. In patient with suitable anatomy who have refractory angina on medical therapy after treatment for non-chronic total occlusion lesions. If there's other lesion, you treat them first. The benefit of PCI to open total occlusion to improve symptoms is not a survival, it's not an improvement in ejection fraction or anything. It is uncertain. So even for symptoms is uncertain at the class 2B. So now you try to make important judgment whether you are going to take somebody with total occlusion, no symptoms, or very little symptoms, and so forth, because the risk of perforation and dissection and other things can happen. And sadly enough, you see some university, like the other day I saw this in university, ingredient of success, why this total CTO treatment team is next level. We spend too much money and energy in healthcare on things that marginal or doesn't matter. And that's why you saw this sad slide in the beginning that I show you, that United States survival life expectancy lower than most of the country that have the same level. The treatment of savinous vein graft, totally occluded savinous vein graft, no benefit of opening graft at all. Treatment for patient with in-stent restenosis. In-stent restenosis, class 1 is a drug-eluting stent. Class 2A is bypass surgery. Class 2B is a brachytherapy. And many people, like even our institution, bought laser therapy, which is not at all in the guideline to treat in-stent restenosis. The hemodynamic support, you hear a lot about Impella and an intra-aortic balloon pump. The classification 2B. Marginal benefit, if any, if it's not equal. In selected high-risk patient, elective insertion of appropriate hemodynamic support device as an adjunct to PCI may be reasonable to prevent hemodynamic compromise. It's not to improve survival. There's no data at all that will improve survival or anything like that, just to prevent hemodynamic compromise during procedures. And the class 2B. The antiplatelet therapy inpatient, I want to emphasize on this one. After CABG, you see patients, they are on aspirin and clopidogrel, and to prevent graft occlusion, to keep the graft patent. As you know, 20% of the graft will close in the first year, and many of them doesn't have a clinical problem. They just close because the surgeon kind of put a graft on any lesion is even 50%. So some of them not needed, and that's why. But in general, those medication only should stay for 1 year, but not longer. The risk benefit of bleed will be more. So you see that in the surgical literature. And here, in some scenarios, we'll do antiplatelet agent after stenting, the dual antiplatelet agent for 1 to 3 months. But that's a specific patient, that's not the main guideline. And that's a class 2A for people who have high risk of a bleed. This is interesting for the beta blockers in patient after revascularization. We tend to have our patient on beta blocker forever after they have bypass or coronary artery disease. If there's a complete revascularization, beta blockers, no benefit after complete revascularization. So that's not something the patient shouldn't be on all the time just because they have coronary artery disease, unless you're still thinking there's some ischemia, level of ischemia, or reduced ejection fraction. Those are the only two things. In general, as you see over the years, and this is a little bit old guideline from 2013, did not really change much. But you see that level of evidence one for bypass overwhelming comparison to the angioplasty. Literally, one vessel, two vessel angioplasty is bypass, BTCA. But in general, any complex condition, multi-vessel disease, left main, reduced ejection fraction, and so forth, is bypass surgery, class 1 indication. And here for the DAPT is a little bit confusing now. Many people want to use DAPT for 1 or 2 months. The DAPT recommendation is still the same. For a stable patient, you use 2 antiplatelet agents for 6 months, for acute for 12 months. So it's did not a change. In terms of the acute coronary syndrome, you are very aware of that. That's a little bit different. That's favoring intervention. So if intervention has major role, it will be in acute coronary syndrome. And as you see, plaque rupture is the main things. Building cholesterol, plaque rupture lead to heart attack. I just want to remind you, every 100 plaque ruptures, one of them would have heart attack, and the rest is not. Our body, the plasmin in our body, dissolve that. The incidence of death right now in the United States with the treatment for ST elevation myocardial infarction is 6.4. Only 4.4, not only, but significant numbers, 4.4 will have cardiogenic shock. For the non-ST elevation myocardial infarction, the incidence of cardiogenic shock is 1.6, and obviously have less in hospital mortality, as you see. In average, the mortality after 1 year of heart attack about 20%, and obviously the age play important risk factors. The age decide what the risk is, and in 5 years 35% of patients will die. But again, with age, if you are 75 years or more, the mortality within 5 years reaching 50 to 60% after heart attack. Now, revascularization of the non-infarct artery in patient with STEMI. The thing that is very clear, that if you have a patient with STEMI and cardiogenic shock, you do not touch any other artery but the target artery, the artery that's causing the problem. Anything else do harm. Actually, this is a class 3 harm. Try not to revascularize completely or more than just the target artery in patient with cardiogenic shock. And that's apply whether ST elevation MI or non-ST elevation MI, both of them. And why? Because the culprit shock trial showed that if you touch any other artery in addition to the culprit, you increase the mortality by 5. If you don't do anything except the target, is better. And that's why those recommendations happen. The intra-aortic balloon shock 2 trial, as you see, there is no benefit at all in shock. And that's why the European classification now, class 3, in the United States is still class 2A, as you see here in this slide. Warren Buffett said there seems to be some perverse human characteristic that like to make easy things difficult. And interventional cardiologists love that. They love to make complex things more complex instead of simplifying them. Revascularization in patient with SCOT, spontaneous coronary artery dissection, the routine revascularization is a class 3 harm. So we try to treat with medical therapy. Only if the patient unstable, then we will intervene on them. Thrombectomy, removing a clot from the artery in patient with ST elevation myocardial infarction, is no benefit. So the other day, not long time ago, I was in the cath lab doing a patient with heart attack, and the first thing the technician told me, do you want the catheter to aspirate this clot? And that's, it's a daily applicable thing. So obviously, a lot of education needed to do. And why? Because the stroke rate is higher. Many of those clots, when you aspirate them, they go through the aorta and they cause a stroke. So the heart failure, always reduce ejection fraction and preserve ejection fraction, 2 types of heart failure, obviously. And now the prevalence, 6 million Americans have heart failure. And here all the therapy for heart failure. But what happened in you right now in heart failure, the SGLT2 inhibitors and the Entresto, those are the 2 that is changing dramatically the treatment of heart failure and the survival. Modeling the survival with the new treatment of heart failure, that including beta blocker, SGLT2 inhibitors, Entresto, and the mineralocorticoid receptors antagonist, like spironolactone and others. That's if the patient on those regimen, their life expectancy now increased by 8 years compared to the standard of care that we just have about 5 years ago. So that is significant advancement in medicine. Ivabradine given only if the patient continue to have heart rate more than 70 beats per minute, despite the beta blockers and all other medication is recommended in patients with heart failure, class 2A. A class 2A, and I don't see it frequently used, and I use digoxin frequently, especially in patients with the acute decompensated heart failures coming to and low blood pressure. So still used to decrease hospitalization, class 2A. Now, anticoagulation, we see that in our CAT conference all the time argument, should we use anticoagulation in patients with low ejection fraction? The answer is no. No benefit for low ejection fraction unless you have AFib or history of thromboembolism event. There must be other reason, not the ejection fraction, and that's very important. Now, also important in heart failure, make sure that the blood pressure's less than 130/80. We don't wait to treat 140, it's less than 130/80, and that's usually the case when you have a systolic dysfunction. And the other thing we need to pay for heart failure, I see it many times, patient on a cardiogram, cardiogram can cause negative inotropic effect over optimal, so shouldn't be used in heart failure patient. That's a class 3 harm, including AFib. If you have AFib but you have a patient with severely reduced ejection fraction, you don't do cardiogram, there's amiodarone or other therapy is more appropriate. In terms of the arrhythmia, obviously AFib is the most common problem in the United States, and the recommendation to use anticoagulation if the CHAD VASA score 2 or more for man or 3 or more for women. That's a class 1 indication. The warfarin therapy is still there for patients with moderate to severe mitral stenosis and mechanical heart valve. Otherwise, if you don't have those two conditions, you can use any of the new agent, whether you are familiar with them, apixaban, rivaroxaban, the bigatran, any of those can be used. Coumadin is still there for those only two conditions of mitral stenosis and mechanical valve. Now, the prevention for stroke, the appendage closure devices, class 2B. People shouldn't be giving option to patient, do you want appendage closure device or you want anticoagulation? Anticoagulation, I just saw you class 1. The appendage closure device, class 2B. So that's a second option if the patient cannot take anticoagulation, and the reason is because of the complication during the procedure. For surgery, sometimes surgical occlusion, also surgery also kind of clip the appendage during their cardiac surgery, and that's a class 2B also. So it's the same, whether surgical or percutaneous. Now, it is not recommended that surgeon go ahead and clip the appendage if there's no AFib. So routine closure of appendage in patient who has no AFib, it's considered the class 3. In terms of the ablation, AFib ablation, ablation might reduce mortality and hospitalization as class 2B in patient with reduced left ventricular ejection fraction. Patient with heart failure, AFib is reasonable. AFib ablation is reasonable, but the class 2B, it's not a huge benefit, but there's possibly some benefit. And it's a class 2A in patient, as you see, this is important. AFib catheter ablation is reasonable for some patient with symptomatic, persistent AFib, which is mean more than 7 days. Persistent by definition, more than 7 days. Refractory or intolerance to at least a class 1 or 3 antiarrhythmic medication. So they have to be refractory to the medicine before you recommend ablation. It's not the first choice, second. In paroxysmal, less than 7 days, and have severe symptoms, recurrent symptoms, then the option between the two is possible, between medicine or ablation. And for sure, the WBW, everyone need to pay attention. All the usual medication that you use for supraventricular tachycardia is dangerous and harmful. The only medicine you can give really procainamide. Now, in terms of the, that's very much for arrhythmia. In terms of the valve, aortic valve, a few points on the aortic valve. Now you're all aware of the TAVI or TAVR. So in patient who is less than 65 years of age, surgery is still a class 1. In patient between 65 and 80, they can go to surgery or they can go to TAVR. It's almost equal. Both of them are class 1. And more than 80 years of age, it will be TAVR, not surgery. So that's the difference. So the age determines what procedure you go through. And when it's come to mechanical versus bioprosthetic valve, the patient is less than 50 years of age, for sure it's recommended mechanical, class 2A. Now, so those are the only few points that I want really to go for the aortic, talk about the aortic valve. For the mitral, the chronic secondary MR, the mitral clip, it's a class 2A. The mitral clip, and the patient have to be chronic severe secondary MR related to ventricular dysfunction, persistent symptoms from class 2, 3, or 4 on optimal medical therapy. This is a critical because almost 60%, 40 to 60% of patients, when you start them on good medical therapy, the MR will change. So that's why it's a critical point here. And in the systolic diameter have to be less than 70. And the pulmonary pressure less than 70. So there's a lot of criteria need to be satisfied before you can put mitral clip. Matter of fact, of the clinical trial, every site was, because this inclusion-exclusion criteria difficult, the site was able to randomize 1.6 patient per year. So that's a critical and important to know. In terms of tricuspid regurgitation, in the guideline, no mortality benefit from tricuspid TR replacement at all mentioned in the guideline. So in terms of the embolic event and the valve, the mechanical valve on Coumadin, they continue to have a stroke, you can add aspirin, provided that the therapeutic level is there. If not therapeutic level, obviously you can increase Coumadin. For bioprosthesis, if patient on aspirin and have a stroke, you just add Coumadin, or replace it with Coumadin, I'm sorry. For pregnancy, the few points to know, ACE inhibitors and ARB, try to avoid them. They can do harm. You can use always beta blocker and diuretics for blood pressure and others. For the aneurysm, now is still the guideline the same. If it's symptomatic, the aneurysm of the aorta will be replaced if it's a diameter 5.5 or more. Or if there is increase in the aneurysm in 1 year by 0.5 centimeters, which is 5 millimeter, or a 3 millimeter per year increase in 2 consecutive years, then the surgery is required. So now if we apply all 5 medications in medicine, as you see here, we can reduce the cardiovascular events, absolute reduction by 15, relative reduction by 77. It's always critical to know the difference between relative reduction and absolute reduction. Relative risk reduction is more a marketing statement. Company love it because they can say cholesterol reduce mortality by 50%. While the mortality at baseline could be 1, and reduce it by 50 to 0.5, from 1 to 0.5. That's clinically non-meaningful. Doesn't mean much clinically, so it's not important. But 50% relative reduction is a huge deal. But if I say the absolute 0.5, it doesn't mean much actually. But that's what it's important. But the medication, current medication we have, number needed to treat to prevent event, cardiovascular event, is 6 if we put them all together. In the United States, we can avoid about 928,000 events with the current treatment. Obviously, there's significant advances in the cardiovascular medicine. I think our biggest problem is the application. We don't realize the risk benefit and the magnitude of the risk benefit, and that's why if we look at the one element, obviously medicine is bigger than cardiology, but in the United States now, the average survival for male 76 and for female 81, comparison to Switzerland 82 and Japan and others. But I think in cardiology, the same, like what I mentioned, cardiology just contributed about 1.3 years on average, even in an advanced country. And the reason I don't think we apply the therapy at the right time for the right patients. And misunderstanding clinical trial is a big problem. You hear many times, one investigator showed one technology better than others, or improvement in something in one hospital. What does that mean clinically? Is really not much. The clinical trial to be a good, well-designed, reduce the confounder and the bias. Here you go. You have to have a clinical primary endpoint, have to be double-blind, it have to be the endpoint at least follow for 6 months, it have to be multi-centers, and have to have a data safety monitoring board and education committees, and have to have a power more than 80% and so forth. So for any data to be valuable, it have to be very well designed, a trial. And we have so many journals, more than 138 journals deal with cardiovascular system, as you see. It's difficult to know what's important, what's not important. And Newton say it's the weight, not the number of experiments, that's to be regarded. And that's critical to know which is really important. That's why the guideline is really important, because there's so many papers and one can get easily lost. And finally, when we talk about patient risk benefit, we always need to know what the number needed to harm versus the number needed to treat. A product can cause a problem, and doctor can cause a problem too. And we have to look at those, our complication versus with the disease versus the disease itself, in addition to the cost. And we need to minimize the bias in those clinical trials. That's what make the difference. Invention is an innovation. Medical product development is very expensive and take long time. We're just going to take only 1 minute. It seems like we reached the time. 1 minute to tell you, maybe in India you can do something also different that we are doing in the United States. Right now in innovation, less than 1 out of 3,000 ideas and less than 10 of startup will succeed. We founded the society, as you heard Dr. Strauss in the beginning mention, truly to expedite the product to patient and reduce cost. Everyone can be inventors, no question. Life experience can provide the raw material. When the brain see unmet need, a redesign and bring in new concept. The problem is the process, and we don't have medical education on how to develop therapy to patients. That's where the biggest problem. We put together here multiple books, multiple online courses on our webpage of the ISCTR on how you develop a product, how you become a good investigators. It will help you dealing with company, with leadership of research and investigation and so forth. And we have webinar and we issue certificate on that. And we have now multiple universities taking those courses, and I'm thinking also, I hope some of you may be connected with India. We can establish such a program in India also. We have now NYU and Purdue University and Arizona and so forth. There's quite a few universities, but also I'm hoping to do that internationally and connect that to India. And thank you so much for listening. I hope this summary of the guideline in cardiology, I try to put the practical point. I hope that will help everyone.